have to click acceptance. Hi, Dr. Gaither.
Hi, Darryl.
Hi, thanks for being part of our conference. Thanks for your time this afternoon. You're a urologist. Can you tell our audience, with more precision what you do and where you do it?
Yeah, thank you. Happy to be here. Yes, I am a urology resident. I'm in my fourth year. And the majority of what I've done, and probably why I'm here, is I do a lot of research in sort of LGBT care, as well as generally what survivorship kind of looks like after prostate cancer in gay and bisexual men, and done that for the past about 10 years or so.
And why do you do that? What got your interest?
Well, I think for me, as I was going through, I'm a gay man myself, and as I was going through medical school and then specifically urology residency, I see that sort of a lot of LGBT care is kind of looked at it sort of like as a secondary thing, and to me, I just saw so many kind of pitfalls and gaps that were kind of there and present that I wanted to kind of be that kind of voice for that population.
That's cool. We've seen two surveys recently, one just a couple of weeks ago and another that an investigative team that I'm part of, that Malecare and University of Minnesota sort of collaborate on. For the survey we're part of, 80% of urologists said that we surveyed said that they do not ask their patients about gender or sexual identity. And one of our colleagues, radiation oncologist from Georgetown, did a Twitter survey, got close to 200 urologists to respond, and 77% said on Twitter, actually posting proud that they don't ask their patients, including many that actually posted comments like, I don't want to, like the classic and really toxic explanations. I don't want to embarrass people, as if like you should be embarrassed, or, and on and on. What do you think of that?
Well, I think hopefully we're getting better as a sort of profession in general, but I think it's why we need more advocacy for it. In my opinion, I think a lot of patients want to talk about it. They want to feel safe with their providers, and they want to know kind of how these different aspects of their life may be impacted by treatment. And if we don't make space for it, it's going to be really challenging for patients to feel heard, and to feel that that their whole sense of self is being kind of taken into account here.
Yeah, heterosexual patients never think twice about feeling safe in a doctor's office, except around medical malpractice things. But what we're talking about is feeling safe. Why do you think LGBT patients, particularly gay and bisexual men with prostate cancer, or even transgender women with prostate cancer, might even, feel unsafe in a doctor's office?
Well, I think it's because a lot of people aren't kind of versed with some of the even lingo, or and I think they're kind of may feel very sort of vulnerable when it comes to talking about sort of different sexual practices and how these things can be affected by treatment. And it can bring up a lot of feelings of like when somebody assumes that you're straight or assumes that you're a certain gender. It just brings out some feelings of, not of people sort of not seeing you who you really are. And that's really frustrating, especially in the medical, I would say, setting, because you want your doctor you want to be able to trust your doctor for sort of everything that you can talk to them about. And so I think it is really, it's one of those things where when you don't feel like this is like, it's almost like you don't feel like this is even for you. It's like kind of for somebody else when somebody, assumes that you're straight. And then you just feel like, man, do I belong here? And those feelings of not feeling like you belong in a certain area, I think, really affect, how you feel.
Yeah. That doesn't necessarily come up in a dentist's office, or perhaps I'm trying to think of some others.
Optometry, maybe even.
Very good. Yeah, unless you really enjoy the way your eyes look or something.
Right.
Well, yeah. Why do you think it comes up for urologists, radiation oncologists specific to prostate cancer?
Well, it's the prostate is involved with sexual health. And that's very, very unique when it comes to sexual minorities, gay men, bisexual men, transgender women as well. The prostate is involved with urination. The prostate is involved with ejaculation. And we're still kind of learning to determine kind of what the prostate's role is in receptive anal sex. But these are all things that come to your mind when you're talking about the prostate as the patient, right? You're wondering, how are all these things going to be affected? And you really want your doctor to kind of at least, again, I like to say the word kind of create space for, because we don't really have a lot of great research in all of this, but at least to create space for, to kind of talk about these different ways in which people have sex.
Yeah, and sex is pleasure, sex is identity, and sex is pleasure, you know. It's also community, obviously you can enjoy sex alone, and many men do that their entire lives. And that's great, or fine, if it's great for, if it's acceptable to, but it is a sense of community, not just on a one-to-one kind of thing, but to be in a room and see other men who enjoy sex in the same way you do and seek out pleasure in the same manner that you do. Prostate cancer treatment impacts that. Can you tell us about that?
Yeah. So prostate cancer, so the prostate, I always like to, the prostate sits right underneath the bladder. And the role of the prostate is to kind of create all the fluid that's in the ejaculate or in the semen. And when you treat the prostate, either with radiation, surgery, there's also coming up focal therapy as well, kind of cryoablation. All of the nerves that kind of go toward the penis pass through the prostate. And those are the nerves that are important for erectile dysfunction. So when you treat the prostate for prostate cancer, one of the most common side effects is erectile dysfunction. The other thing you think about is, because that prostate is right underneath the bladder, it can affect continence. So in terms of holding onto your urine. Those are the two things that we kind of think about the most. But there are also, it sits right in the middle of your pelvis. So it can also affect sort of bowel habits as well, although I think a little bit less so. So it kind of depends on what the treatment is. The other thing it can affect is, ejaculation. So once you have your whole prostate removed, like I said before, it creates all that fluid. You really won't have any sort of ejaculate like you had before. It pretty much goes to nothing. And that can be pretty concerning for a lot of people. So it definitely has an impact on someone's sexual health in terms of genital response. The genital response is very different.
Right, and by genital, you're referring to the penis. Is that
Mm-hmm.
right? Okay.
Yes.
One of the things I've noticed, like with Malecare is like a 23-year-old organization, and we've been running. In fact, one of our first papers was in the early 2000s about ejaculate and the absence of ejaculate. Referencing what you just said, what we've noticed over 2 decades span is that the prostate itself, by itself, is just a critical, is worthy of discussion in the same way that a penis is worthy of discussion.
Mm-hmm.
When we talk, even as you just did, and innocently, and as I do 99% of the time as well, we talk about erectile dysfunction. Treatment will impact your ability to have an erection, but it's also treatment's going to destroy your prostate. That's the whole goal of most therapies, is to
Mm-hmm.
destroy the cancer in your prostate, which unfortunately destroys the prostate itself and most of it. Uh, the prostate is a wonderful sexual organ in and of itself, particularly for gay men.
Mm-hmm.
What are your thoughts around the idea of sort of starting to describe the prostate first rather than erectile dysfunction?
Yeah, it's a great question. It's almost like it makes me think, what is the role of the prostate in the body in general? And it, like I said, it is to make this sort of seminal fluid, but there's a lot of sensory nerves that are kind of wrapped around the prostate, and people have used that to take advantage of it for, thousands of years. In particular in receptive anal sex. And this is really where my expertise are in terms of some of the research that I've done this past year. And really looking at what makes receptive anal sex pleasurable, and really what is the role of the prostate in this. And it's interesting because one of the things that we found was that the prostate is a very important area where people are feeling erogenous sensation during receptive anal intercourse. But interesting, it's not the case for everyone. And so not everyone actually really has an appetite for that sort of deeper rectal stimulation during receptive anal sex. And some people really enjoy sort of just the anal stimulation and the anal sphincters and that sort of thing being stretched, which really doesn't get affected by prostate cancer. So we did a study where we basically interviewed a bunch of people, different ages from 22 to 77, and we just asked people, what makes receptive anal sex pleasurable for you? And then we also talked to people with different prostate problems, and we talked to people who had a prostatectomy, and asked them sort of how things changed for them, or how things have changed throughout their lives as well.
And what did you find out?
And so basically what we found out is that there's two different areas where people enjoy bottoming. We'll say that just to make it kind of more clear. And some people like both of these areas, but one area is kind of near the prostate in the bladder. And that sort of deeper sensation kind of feels like a tickle or an electric sensation and kind of radiate out. Other people, like I said, really enjoy that sort of anal stretching sensation, kind of feels like a stretching, a relaxing, a sort of tickle there. And it's interesting because we talked to somebody who had a prostatectomy, and he said receptive anal sex didn't change for him. And the reason, I think, is because the majority of the pleasure he got was from the more external areas. He actually didn't really enjoy the sort of deeper sensations. And in some sense, I think this is great news to talk to people, because we got to figure out kind of what they like about bottoming. And that might be able to give us an idea of how their sexual function will change after getting their prostate cancer treatments. So yeah, the two main findings were that the major finding was that not everyone enjoys receptive anal sex in the same ways. People feel different erogenous sensation, kind of the pleasurable sensations in different areas. And I think that's really important to not only think about for yourself, but also to communicate with your partners, and also to communicate with your doctor.
Yeah, and communicating with communicating with anyone, but of course, in this case, we're talking about a patient-doctor kind of relationship around. I mean, and our audience, everyone's, the thousands of virtual people watching behind me are mostly men with prostate cancer. Some are pre-diagnosis, but most have already been treated and are concerned with what's next. The conversations don't have the words.
Mm-hmm.
And the doctors, gay or straight, don't have the words either.
Mm-hmm.
I mean, it's almost like I'm thinking now, maybe it's a bad analogy, but that Inuit people have like 100 words to describe snow or something like that, and we have snow to describe snow.
Mm-hmm.
How do you describe what are the words we can use to communicate what we're experiencing regarding our prostate?
Yeah, we have a lack of language for sure around how to even talk about it. And that's one thing that I've been trying to change. And I think we're going to hopefully kind of get there. But if, we don't really have a very good language of talking about even sort of what are the things that we sort of like about insects, in general. But once we kind of, if we can get there and kind of really talk about it, and then everyone can be on the same page, and hopefully we can measure it in a very similar way, we may be able to really understand how certain treatments can affect those certain things. But you're right. I think we have a very lack of language, not only amongst everyone in the sort of the gay community about that, but also especially when it comes to communicating and talking with the doctor about it.
So let's talk a bit about like helpful hints and actual words and sentences that our audience can use in the room with the doctor or
Mhm.
nurse practitioner or radiation oncology, et cetera, et cetera. When a patient gets newly diagnosed, gay man walks into urologist's office. The urologist says, "Guess what?" The patient says, "Do I get a lollipop?" "No, you have prostate cancer."
Mhm.
Once the sort of veil is lifted and the patient goes out for a walk in the sidewalks of his uh, community for an hour and wipes the sweat, comes back to the doctor. What are the sentences? What should the conversation be about specific for a gay man?
Yeah. Well, the first thing I'd say about this is when you're newly diagnosed with any sort of cancer, they have a sense of urgency. And one thing I will say when it comes to prostate cancer is you have time. And that's actually something we've learned throughout the COVID pandemic, is that this is not something that needs to be treated tomorrow. This is something that needs to be treated within the order of months. Even 6 months is okay after diagnosis. So what I would say in terms of what your question is first is that take your time. Take your time to talk to different providers and really figure out what kind of the best decision for you. And I know this feeling that you have cancer in your body and you want to do something about it right away, but there is very, very strong evidence that this is not something that is urgent, that needs to be removed or radiated within a week or two. So the first thing is that. But the other thing is I think that is to really ask your doctor, like, well, how do you think that this is going to affect sex in general, and kind of see where that conversation goes. And then you can kind of pick out some of the things that you feel like is kind of more important to you. And like I said, this is not something that you need to have in one conversation with your doctor, because sometimes it can just be super overwhelming. You have a prostate cancer diagnosis, then you're talking about sex, and most likely the doctor is going to talk about erections and incontinence and all these things, and that's fine. These are good things to actually hear about. And it's totally okay to go back, think about more specific questions, and then kind of come back and be like, okay, now I have these questions as well. In terms of asking, let's just say whether or not you identify with really liking to top or really liking to bottom, and how that will be affected. It's possible that the doctor may not know these terminology. And that's unfortunate, but it's true. Okay. So some people may not know what is the top versus a bottom. And so you have to a little bit advocate a little bit for yourself here, and kind of help the doctor at least talk through these things. When it comes to insertive partners, there's going to be a big focus on erections. And I will say urologists are experts at that. They'll talk your ear off. We know how to deal with this. When it comes to how receptive anal sex or bottoming is going to change, I will say the majority of people don't know kind of anything. And we just don't, the science isn't there. We don't really know in terms of what is best for that. In addition, that the provider education around these issues is also kind of lacking. So I don't know if we kind of always have these answers, but I do think it's totally okay to bring it up to your providers and just kind of talk to them about that. Did that answer your question?
Well, I think our audience would just like to know just a tad more specific. Let's just say the question might be, should I be out to my doctor? Should I just say, have you noticed I'm a gay man? Or, have you had any other gay patients?
Mm-hmm.
What you're describing seems like almost like a clandestine way to get the answers to questions that you have without actually being out. Is that
Mm-hmm.
sort of what you're going after?
No, I think it's important to be out to your doctor. I think it's, I personally think it's very important. I think it's okay to say, hey, doctor, I am a gay man and I'm worried about how this can affect this part of my life. And some doctors may not kind of know exactly how to deal with that, but I think most are willing to work with that, and most are wanting to help you in every way that they can. So I think it's important to at least talk about that. And I think it's okay, at least from a lot of the studies, most patients want their doctor to know their sort of sexual orientation. So it's a little bit person to person dependent. But I think most, I would say 90%, 95% of doctors they can handle that information, and you should tell them.
Yeah, I mean, and I like the way you combined, I'm a gay man and I have these, concerns about X, Y, or Z. Principally, like, what are you going to do to me relative to prostate cancer and stuff?
Mhm, mhm,
Because it's not just about being out; it's about being out with purpose,
mhm,
with a goal. I mean, you're in a doctor's office. The whole purpose of being there is because of your health. It's not like the guy's serving a really, or the lady's serving a really good quality Czechoslovakian beer or something.
mhm,
You know,
correct.
you right. So let not every patient presents with a disease that they can wait 6 months for. I mean, some have like a PSA of 9. I mean, a Gleason score of 9 and a PSA over 100, or they're experiencing back pains, or I mean, something that just raises the red flag as high as it goes and says, you don't need to be treated tomorrow morning or even next week, but we really have to come up with a plan sooner rather than later. Where does being out to your doctor play into that when you feel you have the best oncologist that you could work with at that moment?
Well, it's I think when you're having a little bit more of an aggressive disease state, whether maybe you have metastatic disease, meaning it's spread to some other part of your body, or you have really, really aggressive localized disease, which means it's just in the prostate. I think first and foremost, you want to focus on getting this taken care of, and getting the best oncologic care you can. And that, what I mean by that is, like, you want the cancer, you want to fight for the cure if it's still curable. I think that's important. And you want to, slow the disease process if it's, let's just say, outside of the prostate already. Because I think that if we kind of let it slide and do nothing, there can be some sort of consequences to that, in terms of someone's own mortality, or having more severe side effects. So I would say, number one, my kind of goal in those situations was, let's try to get this treated as best we can. But I still, even in this day and age, I still think that's an important time to still talk to your doctor about, like, listen, I'm, a gay man, I'm a bisexual man. How is this going to affect this part of my life? It's a very important part of your life. And so, that's just kind of how the difference of how I would maybe approach that one.
How would you sort of understand patients who say, I want a gay doctor, I want somebody who's out? I'm not, it may be unfortunate they may not be the most savvy oncologist or urologist, but obviously most doctors are really, really good,
Mhm.
but they don't, this particular doctor doesn't have the reputation, let's say, they're not head of
Yeah.
a department or something, like, what are your thoughts around for gay men seeking out gay physicians and healthcare providers?
You know, I've thought about this, and I think it's important to see the best prostate cancer surgeon or the best prostate cancer radiation oncologist, regardless if they're gay or not. And I really kind of firmly believe this. I think, um, doing a radical prostatectomy is just it's a very niche part of urology, and I think every person, I mean, the people who are these radical prostatectomists, they want to do the minimal amount of harm and get you the best oncologic response, meaning that they want the cancer to be gone and they want to minimize your side effects as much as possible. And I firmly believe that to be the case. Now, there are other types of urologists, and that's kind of more of like where I am coming to play, is more of like this sort of sexual survivorship after prostate cancer and kind of dealing with some of the other things that kind of come out afterwards. And I think that's the time to try to find a gay sort of, or a true ally that you kind of know is going to help you with along these things. And we call them kind of andrologists in the urology world. And these are the people who kind of help with erectile dysfunction afterwards or incontinence afterwards, etc. But when it comes to like actually getting the treatment for your prostate cancer, I would recommend to find the best oncologist at that point, and really get the cancer cured. And every single one of the oncologists that I know and that's been in practice, like they want to cure the cancer. That's their number one goal. And they want to minimize all side effects as much as possible. Um, and I don't necessarily think that kind of searching out a gay specific oncologist in that setting really is what I would recommend.
Yeah, and Malecare follows that theme, and as you know, many of our counterparts don't.
Mhm.
And that's unfortunate from our point of view, and
Yeah.
unfortunately, patients end up suffering as a consequence. The patient isn't just seeing and experiencing time with their doctors. They're also got nurses, they got the receptionists in your, outside your office, and on and on and on, down to the janitors that, pop
Mhm.
into your room in the hospital and sweep out the floor. Uh, to what extent do you, as a physician, sort of connect with those kind of ancillary type folks, or, additional caregivers, you know, um, to sort of clue them in, like, don't, you know, talk about when's your wife coming over, or things like that that are, sort of triggering and not particularly useful in a
Yeah.
in a healing situation.
Yeah, thanks for bringing that up. I mean, I think that sadly there's sort of stigma everywhere along the sort of um, healthcare system in the United States, from when you kind of walk into the receptionist to, to again, like you said, just like people who are bringing you food every day, or in the hospital, or nurses, et cetera. I think within, when it comes to sort of the practice that we have at UCLA, our we work very intimately with all the staff and nursing within our outpatient clinics. These are nurses who are specific for urology. These are medical assistants that specifically work in urology. And I think we have a very good, close relationship with these people that we can try to avoid and learn to kind of avoid these conversations of kind of assuming one thing or another. I think in the hospital, it's a little bit more challenging. There's a big variety of nurses and that typically work on like medical and surgical floors that we have relationships with, but kind of less intimate relationships with. And that is kind of where, we still have some work to do. Not saying that it's, all bad. It's just that I think that there's a little bit less communication between us and them when it comes to patients in the hospital. And so, there are some of those still moments where things like that kind of come up, where there can be some microaggressions, I guess you could say, towards sort of sexual minorities or gender diverse individuals. And, if anything like that ever were to come up, the best thing you can do is kind of tell people about it, because I think, if the more we kind of know about it, the more education we can do to our staff.
Yeah, and it's sort of empowering to stand up for yourself.
Yeah,
If somebody says something or does something, innocently or not,
correct.
if it feels bad, you want to tell somebody because you're in a hospital to feel good or to get to feeling better.
Yeah,
Um, Feeling bad is not the purpose of a hospital. Um,
correct.
but yeah, you're right. I mean, we've had experiences, and we've had like well over 100,000 people come through our system over a couple of decades, and hundreds of little anecdotes of bad experiences in the hospital from heterosexual people too.
Yeah.
But it's good that we have the term microaggression now. It sounds clinical. It sounds too much like out of the mouth of a PhD, or, over-involved social worker or a great urologist. Um, but it's a great term because it's aggression. It's
Hmm.
micro in that you didn't get punched in the face, or,
Right.
it's contained within a moment. But it returns to the idea that aggression hurts.
Hmm.
It's an infliction of pain, and none of us should tolerate that, you know. Plus, we're paying for it here in America for sure. I mean, it's not like, we're on, national health care here. It's
Yes.
so get what you pay for. See, as we close this down, the idea of, and this has been a great conversation, a
Oh,
great
thank you.
warm up for our
It's very fun.
conference. Yeah, the idea of you as a urologist or urology resident, 10 years from now, you'll, become, we'll know you as a renowned urologist. Uh, and you're at a great department with a great department head and wonderful colleagues around you at UCLA. Um, what's really the thing, the one, two, or three things that you would like change tomorrow morning relative to gay men and prostate cancer?
Hmm. 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 Oh man, this is a good question. Yeah, thanks again for having me. It's been a really great conversation. Um, I think one thing that I would love to change, and I think we've already talked about this, and this is from the provider point of view, is I think we really need to create a lot more space for people's sexual concerns after prostate cancer. And we were talking about this before. Sex is very complex. It's not just about the biology of sex, right? There's sex happens in the realm of relationships. It happens in the realm of your sort of societal roles that are or sociological sort of things that you have in the world. You also take into sex. People have sex in so many different ways as well. Like, it's not just like this one particular way. And it just kind of, I think it's really would be nice to have people kind of create a little bit more space for what's going to be the actual issue here. Is it really because you're not going to have ejaculate, or is it because you're afraid that your partners are not going to like you because you don't have that? And I think we're trying to get down to the more of the heart of the issue. I think would be very, very nice. And then on the flip side of that is what I would love to have is some sort of better measures for what is sexual satisfaction after prostate cancer, specifically for gay and bisexual men. Because if we don't have a way to understand and say, like, okay, when people fill it out in this way, they're happy and satisfied. When people fill it out this way, they're not. And what can we do for these people to bring them over to this side of things? And we really do not have that. There's been some kind of things in the works, which is great, but we don't have a kind of a sort of fundamental, what's the standard? And I don't think we even really know what that is. Like, what's the standard of the side effects that we're okay with, and that gay and bisexual men, this population, is okay with? Like, we're okay with this, but we're not okay with this. And we have no idea where those lines are. So if we could have that even tomorrow, at least knowing that, okay, this person's going to be okay, and this person's going to struggle, and what resources can we give to this person to bring them over to this bucket? That would be really, really nice to have. And I think the third thing really would just be that people don't feel afraid or scared, or that they know that healthcare is also for them, and that there's a space for them, and that they're welcome, and that they belong. That they belong into this space. And we as healthcare providers care about these issues. And we see them, kind of for really who they are. And I think some people really feel that in the healthcare setting, but I think we have a very, very, very long way to go to make everyone kind of feel welcome.
Well, it's clear that from the last half hour that you're a physician who truly welcomes not just gay men with prostate cancer, but all of your patients, and will
Yeah,
probably
thank
continue to do so. And we're all grateful for your example, and for the residents that you'll eventually train. And we envy the patients that will be under your care. And
Thank you.
grateful for your time in our conference. Welcome to our conference, and welcome
Yeah.
to Mailcare's faculty.
Yeah.
So,
Thank you very much. It's been an absolute pleasure. And I really appreciate the conversation today.
okay, great. Okay.
Okay.